My name is Sabreen Yousef. I'm a psychiatric physician assistant presenting on Beyond the Cycle, Intro to Women's Mental Health. So we're going to understand how women's mental health can get impacted across the different stages of a menstrual cycle in life. A little bit about me. I graduated with my bachelor's in psychology at UCF. I went to FGCU for my physician assistant degree, and I have a background in women's health before I transitioned into psychiatry. So I really loved working in women's health, but I actually gravitated more towards the psych aspect of it, where I felt like I could make more of a difference and connect better with patients. But I made sure to integrate it into the work that I do today and really try to focus on educating others because I do feel that there is a lot of people out there who don't understand how their hormones and their menstrual cycles can impact how they feel on a either daily or cyclical basis. So, objective wise, we're going to understand the impact that hormonal fluctuations can have on mental health disorders. We're going to identify how there's common mental health disorders in perimenopausal and menopausal women, as well as what kind of leads up to that point, and how the prevalence of those disorders can impact those with ADHD, autism, depression, anxiety, and then kind of go through what treatment options and we have, as well as lifestyle modifications. So just as a little overview, key hormones mentioned today are going to be estrogen and progesterone. Estrogen modulates serotonin pathways, and fluctuations in estrogen can actually impact mood, cognition, emotional sensitivity. We have progesterone, which interacts with our GABA receptors, which promotes like calmness. It's responsible for sleep, um, kind of how we can rest at night, but also stay calm during certain parts of our cycle. How it kind of acts in a menstrual cycle in general, just as an overview. When we go through the menstrual cycle, there's the follicular phase where we're building up our endometrium or the lining of our uterus with estrogen. It's getting ready for a baby, kind of priming it. Though that hormone is secreted by the ovaries, so estrogen, progesterone, and a little bit of testosterone secreted there. And progesterone works by maintaining that lining, kind of cushioning it, and protecting the baby and the baby and the egg itself, the fertilized egg itself, as well as the drop in those specific hormones, if there is no fertilized egg, is what actually triggers the menstrual cycle. So across a woman's lifetime, we're going to have premenopause, perimenopause, pregnancy, menopause, and it looks different in all aspects of those. So we'll be focusing a little bit about what can happen in the premenopausal stage, which also affects perimenopause and menopause, and exploring kind of what conditions like PCOS, PMDD, heavy menstrual bleeding, perimenopause, and menopause can do, and how it can disrupt mental health by affecting quality of life, mental health, essentially our neurotransmitters, and multiple aspects of life. Starting off with polycystic ovarian syndrome, which is a bit of a misnomer. A lot of people hear that and they're like, oh my gosh, there's cysts all over my ovaries. Like, is it going to hold it down or anything? Actually, it's not really cysts as much as it is immature follicles. So it is an indicator that there wasn't ovulation happening. A lot of people actually have PCOS and don't realize it. And sometimes they're on birth control for a big portion of their lifetime, and then they're like, okay, I'm ready to have kids. And they get off birth control and they think, oh no, like it affected my fertility, when in reality, they might have had some underlying PCOS. How is it diagnosed? We usually use the Rotterdam criteria, which means that you need two of the three to even meet it, and two of those three are not even have like indicated on lab work or anything. It can be just by symptoms. So someone who presents with irregular menses, so their periods are, coming every other month, every 2 months, totally unpredictable, not just by a couple of days. Symptoms of hyperandrogenism, so excess male hormones, which can present like kind of on the beard area, excess acne, hair, otherwise known as hirsutism. And then if you do an ultrasound, you might see polycystic ovaries. So just like it's pictured, there's going to be multiple follicles, and that's the follicles that were not released essentially. So PCOS is characterized by we're not ovulating every month. And part of what I was discussing earlier is Estrogen builds up that lining. Progesterone kind of primes it, but it's released by the egg itself. So that's when we get a hormone imbalance if we're not releasing the egg and therefore getting that progesterone in that latter phase of the cycle. If we don't get the drop in progesterone, we don't get a period, at least not regularly, or it might be too late to be a real period to shed that lining. So what does this mean? So it can indicate like infertility or difficulty conceiving. It can put someone at risk for endometrial cancer along the line because we're not shedding that lining properly. So it builds up kind of over time. It can have that androgen excess that make people feel really uncomfortable and affect their body image. So, like acne that they can't control or excessive hair. It could show up on the neck. And then you can have metabolic issues. So it really should be classified as an endocrine disorder, and they are leaning towards that now because it really predisposes someone to insulin resistance, type 2 diabetes, weight gain. A lot of people with PCOS are told just lose weight, but the problem is we're having insulin resistance that's making it difficult to lose weight. So it can become a really toxic cycle of okay, well, I'm eating less, and then that makes their metabolism worse, and then the PCOS gets worse. And it's a bit of a chicken or the egg of whether weight gain can precipitate that, because not PCOS does not look the same in everybody. You don't necessarily have to have gained a lot of weight to develop it, and sometimes it's just genetic. As far as its impacts on mental health, people with PCOS are at a heightened risk for mental health disorders, notably like anxiety and depression. And they have done studies where they've shown those with higher BMIs have a higher risk of depression, and that can be linked to like the body image issues that they struggle with, where it feels kind of out of their control. No matter how little or mu how much they eat, they can't seem to lose the weight or the insecurities around the excess testosterone itself. And that kind of transitions into PMDD, something else that can really affect women's mental health. So PMDD is essentially PMS on steroids. So it's not just your regular, like I'm feeling a little bit me moody before my cycle starts. It's like, no, this person is having debilitating effects before their cycle, and it's usually 7 to 10 days, so in the luteal phase. Um, and this, I always like to screen for this because it can be a really big indicator on whether someone's going to have a rough time with perimenopause and menopause itself, if they've been struggling cyclically with PMDD their entire life. Um, and it can kind of feel like a switch. People can call it almost akin to like feeling like a werewolf, like something just switches in them and they feel totally different. They're having intense mood swings, severe anxiety. It can present physically as well, where they might have extreme breast tenderness, swelling, fatigue, sleeping too much, or not being able to sleep at all. Behavioral changes, so maybe their appetite starts getting affected, or they're not having interest in their usual activities. It can really impact interpersonal relationships as well because of this. As far as diagnostic criteria for this, um, you just need at least one of the following emotional symptoms. So, marked affective lability, so like the mood swings, feeling suddenly sad, tearful, crying out of nowhere, getting really, really angry, um, marked irritability, depressed mood, anxiety, tension, feeling keyed up. So, at least one of those. And in addition, one or more of the following should be present, or at least a total of five. So, decreased interest in usual activities, subjective difficulty in concentration, lethargy, feeling easily fatigued, the appetite changes I had mentioned, sleeping too much, sleeping too little, feeling out of control, overwhelmed, or the physical symptoms. So they're typically limited to the luteal phase, so that's right before your period. And it should affect quality of life for it to be classified for PMDD. You want to make sure you're ruling out anything else that is aligned with that, or something that could be exacerbating it. As far as for mental health, there is a link of suicide and self-harm with premenstrual dysphoric disorder, which is why it's so significant to make sure that people are screening for it. A lot of women could be struggling with it, thinking it's normal PMS, and it's not. It's something that can be treated, um, and something that should be treated, honestly, because this impacts them across the long run. And you want to be able to differentiate premenstrual dysphoric disorder versus premenstrual exacerbation. So PME is essentially the worsening of something that's pre-existing by the cycle. So if we just had PMDD by itself, it's only limited to that time period, and they will usually come to me saying, "Hey, right 10 days before my cycle, if they are aware of it, I'm like a different person. And then as soon as I start bleeding, I'm fine again." Versus PME, premenstrual exacerbation, they could have something underlying. So depression, OCD, anxiety, bipolar, and then it's 10 times worse once their period starts coming. So PMDD is the storm that hits before your period versus PME is a condition that's always there, but the storm makes it worse every single cycle. It matters because it does impact how it's treated. So versus like, okay, we've got this hormonal condition, let's focus on this time period, versus like, no, 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 we have this baseline OCD, it just gets 10 times worse right beforehand. So we're just going to have to accommodate for that. There also is a link with PMS and ADHD. So I've across the board screened for people's cycles, and I screen especially if there is underlying ADHD, because there's a link between estrogen and dopamine. So estrogen enhances dopamine, and right before the period starts, we get a drop in that. So if we already are struggling with dopamine and then our estrogen drops further, you'll see worsened focus, executive functioning. People might get more impulsive and emotionally dysregulated. If there's not a connection drawn between that, a lot of women with ADHD could be mistaken as bipolar. If you can kind of see that overlap there, where maybe someone would appear hypomanic if they're like undiagnosed ADHD and they go to their provider and they're like, I don't know, I'm like making decisions I wouldn't normally do. I'm like talking too fast, or I feel out of control. All the things that would lie overlap with PMDD, but it's actually PMS and ADHD and strictly linked to their cycle. And there also is the progesterone impact, which like it typically should rise during luteal phase. It can make people feel more unstable, as PMDD can just be an intolerance to a fluctuation in hormones. It doesn't have to necessarily be a hormonal imbalance. So like, things that they might start like complaining about is, oh, my brain fog is worse. I'm feeling forgetful. I'm feeling more reactive or irritable. Especially like two common places is going to be at home and at work. And ADHD medications overall might be less effective at the current dosage during that time. So like it'll feel like I took like a sugar pill. It doesn't feel like I took anything at all. So as far as for PMDD and PCOS, honestly, symptom tracking is really important. So tracking in the first place to be able to kind of notice, all right, when is this happening? What's going on? Is it like limited to this time and or is it the entire month and only getting worse during this time? Some people say that when their period starts, it gets better. And for others, I've seen it take up almost half the month. And those are the ones that are usually struggling with comorbidities of depression already underlying. And there can be stress management, timing around it. Like I know this part of the month is pretty difficult for me. Maybe make sure I plan accordingly. Maybe my energy levels are a little bit lower, and I need to make sure I don't have too many social events. Do we need to change the dosages of meds? You know, some people need an extra booster during that time for their ADHD meds. In terms of ADHD, a lot of times what can happen is when we have high functioning individuals with ADHD, they can start outsourcing it. So if we're getting like that drop in estrogen, that drop in dopamine, what can often happen is they're looking for it in other places. So I will often see like increased caffeine intake, maybe snacking throughout the day constantly. They'll complain like I just can't stop snacking on junk food. Um, it can look like needing that extra wine or two at like the end of the night, where it's just like, I don't know, I just need something to calm me down. Or even using stress and adrenaline. Like I can't get things done. So I am using kind of shame and anxiety to drive myself further to get it done. None of these things are very sustainable. They can work and be effective. But for someone who already struggles to focus as baseline, PMDD can be extra debilitating. for someone with ADHD because they're already using these unhealthy coping mechanisms, but things that are working for them right now. And then it gets like significantly worse right before their cycle. So I encourage those with ADHD to see a psychiatrist no matter what age, because over time, outsourcing that dopamine will take a huge toll on mental health, leading to burnout. Um, they'll kind of come to me being like, I can't do the things that I normally can do, or maybe I had developed autoimmune disease from this chronic dysregulation. And also just the impact on mental health of relying on anxiety, shame, and adrenaline to complete tasks. I usually like here, I do my best work under pressure, or I should be able to do this if only I weren't so lazy, especially like with my patients that are women, like they tend to kind of internalize that and think that like, okay, I'm the problem, I'm lazy. And I always like to provide that reassurance, like, hey, if a lazy person would not be crying about that. Um, you're not lazy. It just means that we have a system that doesn't work. For every I should or I need to, it means that we need a different system. This is not sustainable. So key takeaway, PMS is not just a physical challenge. It directly impacts cognitive and emotional functioning, and we need tailored adjustments for each person. Everyone is different. PMS can also affect autistic people. So that is also highly comorbid for PMDD and autistic folks. They already have pre-existing challenges where there are sensory issues, emotional issues, social challenges, and now this phase is particularly difficult for them. It has disproportionately affected those with ADHD and autism, so it's just part of my screening process for that in general. With about 92% of autistic women and 46% of women with ADHD experiencing PMDD. Yeah, estimates can vary, obviously, depending on whether who's diagnosed or not. And I had mentioned earlier there was no agreed upon cause of PMDD, so it's not always a hormonal imbalance. It could be an intolerance to fluctuations, it could be genetics. Um, Regardless, it is something that people are struggling with, and it can be a struggle in silence, unfortunately. So, what is the most important thing to ask about their periods in general, which often surprises a lot of people? Because if it's a problem, they would talk about it, right? Except this might have just be their baseline, so they won't know to talk about it. I just make sure that like we focus on bringing up the topic in the first place, whether um, they're menstruating or not. Like they could have a IUD and still be experiencing PMDD. Maybe it's something uncomfortable to ask because that person doesn't identify as a woman or they're assigned female at birth. And someone might feel uncomfortable asking about their menstrual cycles, but they're also someone that's going to experience this. So asking about it, bringing it up, making sure that we're screening for it is so important in mental health and for clinicians in general. And that kind of brings me to the point of interoception because, like I said, a lot of people would think if it was a problem, it would be brought up, right? Except interoception kind of gets in the way of that. It's that mind-body connection that neurodivergent people don't necessarily always have. I kind of describe it to my patients as you are driving your car and you look on the dashboard and that little signal comes up, and maybe the signal should be saying, "Hey, it's t your blood sugar is dropping. It's time to eat. It's been a minute since you've had a snack," or "It's really loud in here," or "You really did you notice you're really hot? Like you're kind of getting like you're sweaty. You're kind of hot. Maybe you should just take a second or go back in the AC." Like all these little signs kind of coming up, and that person's just like, "I don't know what that means. I'm gonna keep driving until." That smoke comes up in front of the car and they're like, oh, you don't really like know when you're in the yellow till you're in the red, essentially. So asking is important because for that person, they might not have made that connection. And if someone seems uncertain if there's a pattern, because I've had those where they're like, no, I don't think so. And I encourage them to track anyways. Track anyways because you never know. It could be that interoception and struggling to make that connection. Maybe that person's a mom and just always on the go and doesn't have time to worry about themselves, and or make the connection themselves. So I tell them, track on an app, whatever's easiest for you, work with your brain, not against it. keeping food diaries to see if there's any intolerances. Document how much sleep you've been able to have throughout the month. Does it drastically drop during certain times? If you have an episode of something, whether it's like a meltdown or they come to me and they're like, I don't know, I had a really hard time at work and I kind of blew up on someone. I'm like, you know what? What happened before then? Did we have anything to eat in the last 2 hours? How much water did we have to drink that day? And also, where are we in our cycle? Like, those are my first three questions for anyone that comes to me with an acute issue. So, kind of circling back to the impact of neurotransmitters, estrogen affects serotonin and progesterone influences GABA. So, when we have those fluctuations, that's when we kind of get issues with perimenopause because with PMDD, it's pretty cyclical for most people and they can start to predict it. I mean, you throw PCOS in there and then it gets really hard for them, unfortunately. And then perimenopause, it is a roller coaster because perimenopause is pretty much characterized by just different fluctuations in hormones, which can bring a surge in mental health issues driven by that hormonal inconsistency. So it's that transitional phase before menopause when the body undergoes hormonal changes, primarily a decline in estrogen and progesterone. It typically begins in 40s, but I have been seeing it as early as at people in their 30s, and I really personally feel a connection with that chronic dysregulation or trauma kind of can bring it on earlier for certain people. Um, and it's impossible to detect how long it's going to last for someone. It could last a few months to years. How does it present? Well, it can start with menstrual changes. So maybe someone was regular for most of their life, and all of a sudden their cycles start getting shorter, and it's happening every 2 weeks or every 3 to 4 weeks. You can get heavier bleeding or lighter bleeding. Ideally, someone would probably like to get lighter bleeding, but most of the time I notice their cycles will get a lot heavier. You get the vasomotor symptoms that people are aware of, so hot flashes, night sweats, it can start kind of just occasionally. And then the mood swings that are associated with it. Some ones that were more predictable now are kind of all over the place, and it feels like there's no control over it or rhyme or reason. There are physical changes, so a lot of women will come to me very insecure about fat collecting around the abdomen. Those are there changes in skin texture as estrogen does help the skin stay moisturized, so it may start getting drier, and hair thinning as well. And characterized as atypical symptoms, but very typically seen difficulty concentrating, brain fog, memory lapses, trouble with word recall. They might have generalized joint pain. Estrogen helps joints. So as we see a decrease in estrogen, you can start getting the joint pain that's associated with that or vaginal dryness as well. And sleep issues predominantly, which is what's related to that progesterone and GABA I had mentioned. So that's one of the first things that I people will normally start complaining to me about is they're like, oh my goodness, I cannot sleep. Like I didn't really have that many issues sleeping before, but I'm either too hot or I just can't stay asleep. Well, how does that impact mental health? I mean, depression and anxiety are highly comorbid due to those hormonal fluctuations. Women feeling like they're out of control of their bodies and they don't understand, like, why am I crying all the time? I feel like ridiculous, or I don't feel like I know how to stop it or predict it. The perceived memory and focus issues can cause them a lot of frustration. They're like, I'm forgetting things, I'm having to write notes everywhere and then forgetting about the notes. These are women that are working full-time jobs. They're also still full-time moms. They're trying to stay on top of everything. And things that they were doing before, they're not able to do anymore, whether that pre-existing ADHD was there or not. Brain fog being a part of the picture and lack of sleep is going to significantly impact them. And then comes the heavy menstrual bleeding. So this is something that I notice a lot of women will actually undermine the importance of because they're so on the go, because they're so busy with life. They don't realize that the amount of bleeding that they're having every month is having such an impact on them. And if there is any comorbid condition, so Things that can happen in someone's 40s, like fibroids, which are benign growths essentially on the uterus that can cause really heavy cramping or bleeding. Things like adenomyosis, which also causes heavy bleeding and cramping. Um, they start dropping in their iron and their ferritin. They're feeling tired. They're feeling like just fatigued, drowsy. Um, and unfortunately, their symptoms are not being taken seriously by a lot of providers. Like, oh, that's part of life. You're a mom, or that's what happens when you're approaching your 50s. When in reality, I'll run a panel on them, and ferritin that's ideally should be around 50 for women to feel good is like at a 7 or a 5. And I'm like, oh my goodness, of course you feel horrible. But that kind of physical toll on their body is going to take a toll on their mental health because they're not going to be able to do the things that they can anymore. And that's going to affect how they feel about themselves. And then we get into menopause, where we have the lowest amount of hormones available to us as women. So, menopause is the natural and permanent cessation of menstrual periods, ending the reproductive cycle. Technically, to diagnose menopause, the number one and only way is supposed to be 12 months without a period. So, we're not generally supposed to do it through blood tests. Um, and that's when it can kind of get tricky when people get confused. And yes, if you start bleeding 8 months in, it does start the clock over, unfortunately. On average, people in America will go through menopause at around 51. Sometimes I'll ask if someone's like what age their mom went through it, because maybe genetics can kind of tie into it, but there's no way to predict it essentially. Periods coming closer or farther apart, it still could be extended. And then we have people that are either have the IUD in or they had a hysterectomy, and that can complicate it further because they're having the menopausal symptoms of hot flashes, night sweats, difficulty sleeping, but have no idea when it's happening for them. So it's going to be similar to perimenopause, but more amplified. And it can kind of depend on the significance for the person. So some people have really, really bad perimenopause and they already feel like they've been menopausal for a long time. And others, it's just little lapses here and there where they're like, okay, I had a couple hot flashes and now it's every single day, all day. So it's going to be that associated drop in estrogen leading to the hot flashes, vaginal dryness, discomfort during sex, the drop in progesterone that leads to just sleep disturbances and eventually fatigue. The mood swings, irritability is the biggest one, like I'm snapping at my loved ones. And then there's the health impacts as well. So estrogen is tied to cardiovascular health. It's protective of your heart. So your HDL is actually reflected with your estrogen as well. So that could drop. And estrogen is responsible for your bone health too. So any risks for osteoporosis can increase as well, depending on someone's declining estrogen levels. So we're going through all of this, and there has to be a solution, right? Well, with PCOS and PMDD, generally, it's birth control, lifestyle accommodations, tracking. Now it suddenly gets complicated when it comes to perimenopause and menopause, and that's because HRT has been so stigmatized. A lot of women have been turned away when they request hormone replacement therapy for quality of life purposes. And why is that? Well, unfortunately, something called Women's Health Initiative trial was released and kind of caused a lot of misinformation. So it was a large-scale study done in 1991 to investigate the effects of hormone replacement therapy, as well as diet modification and calcium and vitamin D supplementation in postmenopausal health. So it focused on the impact of estrogen-only therapy and combined estrogen and progestin therapy on heart disease, breast cancer, and osteoporosis. So the key findings that were published in 2002 were an increased risk of breast cancer, increased risk of stroke and blood clots, and no cardiovascular benefits, with maybe some reduced risk in osteoporosis-related fractures and some clinical relief from the menopausal symptoms. However, this was not done well. It was actually done on postmenopausal women, which is not when HRT is typically indicated. So you want to give hormone replacement therapy either when they're experiencing perimenopausal symptoms or within 10 years of menopause. So these studies were done on participants that were averaging at age 63. So that's why they were so high risk for all of those things. That's not something we would do nowadays. If you know you have menopause at 55, yeah, you could actually do it until 65. However, like I said before, average age was 51, and unfortunately, everyone was predominantly in their 60s. So yes, they had higher risk of blood clots, higher risk of breast cancer. Um, so it unfortunately did set a standard for practitioners to be very scared to prescribe it in the first place because they're like, no, no, I don't want to touch that. And even though it's been disproven and there's been further studies that have come out, unfortunately, there's still media that's kind of sensationalized that, made it seem like it's dangerous, so a lot of them are scared, or there are clinicians that are still scared to prescribe it. So, like when they reevaluated it, they realized HRT is safe and beneficial for many younger menopausal individuals when started earlier and tailored to individual needs. They did see a reduced risk for osteoporosis, a reduced risk for cardiovascular events, including heart attacks, improvement in cholesterol, improvement in quality of life, most importantly, because it's not just a part of life where you should be suffering, and that's unfortunately normalized for those with uteruses. You know, it's normal to have painful periods. It's normal to feel horrible before your cycle begins. It's normal to bleed heavily. The things that I've heard patients tell me, it's just so disheartening because it's not. We don't have to suffer unnecessarily. You know, we can improve your hot flashes. We can improve your quality of life and sleep so that you can still enjoy yourself and be present in the moment and not struggle until your periods stop completely. There are several different approaches. So whether someone is a candidate for HRT, that can help. SSRIs can also help modulate like those kind of intolerance to fluctuations in hormones too, the same way that they can help in PMDD. Um, they can do CBTI for like trouble with insomnia, CBT in general. Um, a lot of women, you know, have learned to carry the world on their shoulders, especially when mothers come to me. And sometimes just have to encourage them to, I'm like, it's okay to put it down and communicate that you need help, that you can't do some of the things that you could before. And maybe you shouldn't have been taking on so much of the role in the family. And it's okay to pause and be like, hey, like I need help with this. I need help. I'm adjusting my lifestyle. I need help. I need to talk to somebody about how I'm feeling. So I try to emphasize, even from a holistic perspective, emphasis on omega-3s, vitamin D, exercise, protein, sleep hygiene. All those things are going to be extra important when we're struggling with them in the first place. So, you know, making sure we have that routine for bedtime, that even when we put the kids to bed, we're also having a set a time aside for us to just sit down, light our candle, like let our body know this means it's time for bedtime. We're not on the go all day every day, as well as emphasizing balanced meals, protein across a woman's lifespan. That's going to be super important. Um, a lot of people with PCOS, PMDD, any of these disorders or perimenopause, menopause, when they're struggling with that, there's such an on-the-go lifestyle that's like, well, I just grab my coffee and head to work, and then I wait till I'm really, really hungry at lunch, and then I eat a high-carb meal, and then I crash around 3 or 4, and then I get home, and then I start binging, and it's like this really just unsustainable cycle of where now we're leading to poor sleep, insulin resistance, feeling horrible overall. So kind of reminding kind of people to go back to the roots of what medicine is and should be, where instead of just saying, hey, eat less, it's like, no, let's focus on what we can add. What can we add to our life? What can we add to our day? Little moments here and there to make sure that we're doing okay. So mindfulness, meditation, yoga, taking time to just do something that's not intense. Fortunately, I still do see a lot of women that be like, no, no, I got to do high intensity interval exercises. I need to do more. And I'm like, no, no, no. I'm giving you permission to do less. Oh, your body is asking for you to do less right now, and it's okay to. And then comes hormone testing, which, I'm not feeling good, I'm not doing okay, instinctually asking for hormone testing. And this is something I spend a lot of time trying to educate on because unfortunately our hormones will change on a day-to-day basis. So each day you can get a different estradiol level, progesterone level. They naturally fluctuate throughout the menstrual cycle, and timing is crucial, but indications are also crucial for hormone testing. So if we just did it on any random day, you go to your provider, you're like, I just need to know what my estrogen and my progesterone are. Most of the time, it's not going to be very accurate unless you're doing like day 3 for baseline for your estrogen and like 7 days before your period starts. So that would be considered day 21 if you had a regular 28-day cycle, indicating like, okay, are your progesterones normal? Did you ovulate? So doing it on any random day is not very helpful, but also we should be testing hormones intentionally. And I will hear a lot of providers get really frustrated with people when they ask for this, when in reality we need to be educating, like, okay, why is it not helpful to test hormones versus when it is? So trying to determine if someone has polycystic ovarian syndrome. Um, First of all, this is in the setting that we're not taking hormones. If you are on birth control of any kind, it's not helpful to test hormones because it is not accurate. We're inhibiting ovulation, so we're not no longer getting the normal amount of hormones we're supposed to be getting. So it's only accurate if you do hormone testing 4 months without birth control. 4 months, I apologize. 4 weeks without birth control at minimum. So if you're on any type of birth control, it's not going to be helpful. But let's say there's no birth control on the table. If we're trying to determine if someone has PCOS by testing maybe testosterone levels, see if they're elevated. If we're testing someone in perimenopause to see if their testosterone levels are too low, and if we're considering hormone replacement therapy, premature ovarian failure. So, did someone just stop having their period at a really young age, before the age of 40? That's really significant because I had mentioned before, estrogen is so important for our cardiovascular health. I have had a patient come to me with like 3 heart attacks in her mid 50s, and unfortunately, she had gone through premature ovarian failure and had never been given HRT. And she had severe osteoporosis, and that was why. And then it was so disheartening to hear. I'm like, oh my goodness, this could have been entirely prevented for this woman, but because she didn't get the estrogen she so desperately needed at a young age. Um, if we're trying to test for menopause, that's when it gets tricky. There's no way to test if you're in perimenopause, and if you don't have a uterus, we can kind of guess you're in menopause if your FSH is over 20. Otherwise, it's still 12 months without a period. If it's a certain level, though, we can kind of assume that it's you're in menopause, but it makes it very difficult. And then if someone is wanting to do HRT, starting HRT, that's when we start testing as well to make sure we're in an ideal optimized area. But if it's just for like PMDD and just seeing, I don't know, do I have a hormonal imbalance? Unfortunately, it isn't actually that helpful to test for hormones because you have to look at the outcomes. When you're premenopausal, it's typically going to be, if you're going to a clinician, it's going to be birth control, um, regardless of like what it comes back as. So I always try to educate those, instead of trying to get frustrated with them because I understand they're looking for answers. They just don't understand the limitations of it. So yeah, trying to set those limitations, set those expectations of what we can get out of hormone testing, what can affect it. So depending on what timing is done, um, like if they're on birth control, if they're under significant amount of stress, if there's any eating disorders, that's also a good indicator of probably testing for hormones, to be honest, but it can also impact their health if they have autoimmune conditions, going to impact hormones. So taking that time to explain what it can do and what it can't do is so important. Um, but that's why psychoeducation and patient education is important in general, because people should understand what's happening with their bodies before they take the next steps. I hope that was helpful. I really am passionate about educating women about what's happening inside of their bodies. And if anyone has any questions, I'd be glad to answer.
Thank you so much. That was very insightful. I do have a question. So I saw that PCOS is being called PMOS or something like that.
Um, you know what, you're right. I had just seen it too because I try to stay up to date. Um, I forget what they're going to try to call it now, but the emphasis is that it's an endocrine disorder because they're trying, with the current name that it has, it's focusing too much on, oh, it's just an ovarian problem. No, it's a whole body problem. It completely affects that person's metabolism. So, like telling someone, okay, birth control is protective. It is important for PCOS because if we're not shedding that lining, they're at risk for cancer. But it's affecting their metabolism and causing them to also gain weight and develop diabetes. So I believe that's why they're making that change so that we can kind of take away that stigma and misinformation that people have, but also a lot of providers can have around PCOS, where it's not just a period issue, it's a whole body metabolic endocrine issue that's going on, and it's not something that they caused, which unfortunately is some that like people have that preconceived mo notion of, well, they ate too much and gained weight and caused PCOS. No, like people with very low BMIs have also had PCOS too. So yes, they are working on changing the name, and it is to kind of take away from that. I just cannot for the life of me remember what it was again.
Okay. Yeah, because I was wondering like why. But talking about stigmas, what is something that you've found that a lot of people have the wrong thoughts about or like the wrong, you know what I mean? Like,
Yeah, no, yeah. Um, Honestly, everything. Probably mentioned. Um, it really depends, like from a clinician perspective or a person experiencing it.
from a clinician's experience, based on what the people come to you talking about, and you're like, oh, no, no, actually, honey, that's wrong. Like, this is what it is.
Well, that's why I always include the hormone testing because, unfortunately, like people come to me thinking that that's the solution. It's like, well, if I can just test my hormones, we'll figure out what's wrong, right? And I'm like, well, not really. And it's not going to necessarily change the outcome of what we're going to do. And that's why I try to take a whole body approach and I screen so carefully. Um, because it is really discouraging. They go to someone for hormone testing, they don't get answers, and they're like, oh, they just gave me birth control and sent me on my way. Versus ex kind of going through, okay, what is, I go to the basics and I'm like, okay, what does your morning routine look like? Are we skipping breakfast? How's our sleep? We have to go down to the very roots of it and work our way up from there. So I think that's probably the biggest misconception people can have coming to me is thinking like, okay, she's gonna test my hormones and then it's gonna be okay. Where I'm like, well, I'm actually going to ask you about everything. And we're going to work from the bottom up and it's probably not going to be really easy, but it's going to be worth it.
Okay, I did see something in the chat. Let me. Okay, so Bonnie said, you covered a lot in a short time. I'm 65 and have dealt with some of these issues, have no uterus, but still have the hot flashes and sleepless nights.
Yeah, so that's when it kind of gets complicated of like, when did this person go through menopause? So in that case, it would probably be beneficial to do hormone testing to see like, okay, FSH essentially is your follicle stimulating hormone. So that's released by one of your glands kind of like just like taps on the uterus like, hey, or the ovaries, you gotta make your hormones. And the ovaries don't respond because they're not making hormones anymore. So FSH makes more, like, hey, keep doing it. And so it gets higher and higher and higher. So that's when I was kind of mentioning, like, maybe we can test that sometimes. And if it's over 20, then it indicates someone is menopausal. But not a lot of providers will feel super comfortable prescribing estrogen over 65 because of those studies. But if you're still having hot flashes, it might indicate like you're not fully menopausal. And if you have a family history, like maybe your mother went through it a lot later, um, like a lot, if you can find an experienced provider, they will do it with close monitoring. And if you don't have comorbidities, you have to look at risk factors too. Does this person have hypertension, high cholesterol, and obesity, things that can put you at risk for getting a blood clot, because that's going to be everyone's biggest concern, honestly. But I have seen people mid 60s be on hormone replacement therapy just at low doses, and you can do like the patch, cream. Those are going to be less blood clot risk because they're bypassing the liver.
Well, that's interesting. So I know my mom went through menopause before. She's also 65, I believe. So she went through menopause before, but now recently, in the recent months, she's been saying she's been getting hot flashes. So is that something you could have twice?
I always I always try to explore like if there's been any changes. So I'm really big about timelines. I'm like, okay, what I want you to walk me through the entire 6 months to a year before this symptom started. Has there
Mhm.
been changes in routine, changes in medications? Because medications can cause side effects that we don't even like think about. And it can be uncommon medications or even SSRIs can cause it. Are there any associated symptoms with it? You don't typically go through menopause twice, so that's when I would start looking at outside factors and making sure that we're getting lab work done to see like, is it hot flashes? Is it night sweats? Is there anything else going on? Is it a side effect of a medication? Um, Especially if she's in her mid 60s, because I would think early 50s, maybe we thought we were going through menopause and we didn't, or it's fluctuating, or it's Florida. But that's going through menopause in Florida. Like I feel for them. Um, but yeah, I would that's when I would start exploring with primary care, like, but getting a timeline ready for them, honestly, being like, hey, this is everything in the past year. What could it be any of these factors? Because it shouldn't be menopause. I would actually get lab work.
Let me just check Facebook, see if we have any questions over there. All right, Sabrina, well, thank you so much for taking the time to be here with us and give us all this knowledge. I know we all enjoyed it, and it's amazing all the things that the body does that we really just don't know. And you have really, I'm sure you have expanded all of our minds.
Glad to hear that, and it's such a pleasure. I really, like I said, I enjoy doing this. Um, I think that every woman should be empowered to learn about her body, honestly, so that she can better help herself.
Absolutely. Yes. So important.
It's been a pleasure. Thank you guys for having me.
Absolutely. Thank you. Have a good night. Have a
Have
good
a
night,
great night,
everyone.
guys. Bye-bye.